Okay, so welcome everyone to our monthly SIPSI enrichment seminar. I'm Jingjing Sheng. I'm sorry, Pat cannot be here today. Today we will have our two pilot PIs present their projects. So we have Dr. Maureen George and Dr. Bevin Cohen. I'm going to let them to talk about their topic and then the start their presentation. So I think Dr. George will start first.
Okay, can you hear me? Okay, great. Thanks for this opportunity to talk about my pilot, which is focused on the development and pilot testing of a brief shared decision-making intervention to improve palliative care outcomes for adults with advanced lung disease. So the World Health Organization identifies that palliative care is an appropriate service to implement to improve the quality of life of both individuals and caregivers through the prevention and relief of suffering by identifying, assessing, and treatment a variety of problems that are associated with life-threatening illness. And in the case of my pilot, we are looking specifically at symptomatic advanced lung diseases, or ALDs, as those life-threatening conditions. And these include the broad categories of COPD and ILD. So just briefly to talk about the differences between these diseases and their commonalities. COPD is a chronic obstructive pulmonary disease, which is chronic and progressive. And as shown in the bottom of this slide here, results in the permanent destruction of the distal small airways, as well as the air sacs or alveoli. Because of the redundancy within the lungs to sustain injury over a long period of time without loss of function, this disease actually presents quite late in life. In the United States, the #1 cause of COPD is cigarette smoking. And this map shows the current data for prevalence. So the darker states representing those states that have the highest rates of COPD. In total, about 65 million Americans are known to have COPD, but really the actual number is unknown because of the delay in the diagnosis of the disease as a result of that sustained injury without loss of functioning. Means that individuals are not getting diagnosed until later in life, 6th or 7th decade, when they have more advanced disease. These states in the darker colors of red and dark brown, representing the states of the South and the Eastern Midwest, which have traditionally been the regions that have produced tobacco and continue to produce tobacco, also representing those areas where there have been the highest smoking rates. Globally, about 3 million people worldwide will die from COPD by the year 2030, which will make it the 3rd leading cause of global deaths. It's also interesting that there have been changes in the demographics of those who have morbidity and mortality associated with COPD. Since 2000, actually more women than men are dying from COPD, making it the 3rd leading cause of death behind cancer and heart disease for women. And women are diagnosed later than men, and women get the disease earlier in life with less smoking, which may speak to some of the specific environmental challenges, as well as airway anatomy that are specific to the changes that we're seeing. Women also disproportionately are being exposed to other causes of COPD worldwide. which includes biomass fuels used for cooking and heating indoors, which causes indoor air quality concerns, leading to more women than men globally having COPD, maybe not from smoking, but because of these exposure to biomass fuels. In contrast, the interstitial lung diseases really represent a heterogeneous group of diseases, restrictive lung diseases, and they may include things like interstitial pulmonary fibrosis or sarcoid, or if you're thinking more about what we're seeing in terms of individuals who are developing long-haul COVID symptoms related to mechanical ventilation for COVID, they're developing these kind of scarring or fibrotic pictures in which there is both scarring of the lung tissue as well as damage to the alveolar spaces. It's a chronic progressive disease with a wide range of life expectancy because there's a wide range of disease severity spectrum within this heterogeneous group of over 200 different diseases. Again, prevalence is not clearly known, but in the United States, there is an estimate that we have a rate of about 100 cases per 100,000 that are specific to this interstitial lung disease group. So COPD and ILD share a common presentation and some similar challenges. They are occurring later in life, therefore they're often occurring in the setting of multiple chronic conditions, that they have a relatively complex treatment regimen that has to be considered within the treatment of their other multiple chronic conditions, and also requires nutrition as well as physical activities in order to maximize function. The common symptom clusters that COPD and ILD share include a progressive breathlessness, progressing to breathlessness that occurs at rest, overwhelming fatigue, a reduced functional capacity resulting in decreased mobility, a lot of symptoms of cough, mucus, and chest tightness, as well as impaired sleep. So to improve these outcomes, there's a need to implement, as I said before, a complex combination of medications. Often there's a need to stop smoking, to engage in some pulmonary reconditioning, general nutrition, as well as individuals, in some cases, needing long-term oxygen therapy. But there's barriers to self-management and to getting the kind of assistance that patients might need from their healthcare team. In a study that's been reported of patient-endorsed barriers, 65% of patients with obstructive lung diseases never spoke with their healthcare professional about the types of treatment they wanted if they were to get too sick to speak for themselves. And 3/4 would rather concentrate on staying alive than talk about death. But symptomatic advanced lung disease would be improved by palliative care. However, adults with ALD are not often referred to palliative care for a variety of clinician-related specific reasons, including pulmonologists lacking the time to discuss palliative care during office visits, pulmonologists reporting a lack of confidence that palliative care teams can deal with non-cancer patients, and a belief that palliative care would pose a threat to the relationship they've already established with the patient. Because of these high rates of symptomatic diseases as well as excessive morbidity, you can see that there are high rates of hospitalizations and emergency department visits that are really driving the primary costs of these disease, resulting in about $49 billion in costs for COPD and nearly $2 billion for ILD. And these are primarily related to acute healthcare utilization, but there's also indirect things like shorter survival. So as I mentioned before, their adherence requires complex treatment of pills as well as inhalers, and these inhalers are delivered through a variety of different devices. And there's no factors that reliably predict adherence. We know that adherence to controller medications ranges in the neighborhood of about 50%, that oxygen therapy use of greater than 15 hours per day, which is what's needed for long-term oxygen therapy to be effective, again, in the neighborhood of about 50%. Only about half of people who try to quit smoking are successful, and very low rates of acceptance to telehealth programs. So just to show you a little bit about this particular issues of adherence and persistence in COPD, I do want to talk a little bit about what we're seeing in large data sets. So adherence is a good quality of therapy implementation, meaning there's a regular intake of medicine as recommended, with persistence being no critical gaps in that treatment period. So from large data set analysis, we can see that there is a variety of adherence and persistence values across a variety of different disease. But if you look at COPD on this slide, you can see that only about 40% are adhering to their therapy overall in a 12-month period of time, and only 35% are persistently adherent over a 12-month period of time. And so what you see is that very quickly, within about the first 30 days of treatment, there is a big drop off to where about 25% of patients are no longer taking their medications. And then around 3 months out, you see another big drop in adherence, so that about 50% of adherence is seen by 3 months of treatment. And then over the course of a year, you'll see that there is continuing drop off in persistence till you reach that 35% rate that I was describing before. And the non-persistence does differ by class of drug, but still is kind of disappointing that there's better persistence with the use of bronchodilators, but lower persistence to inhaled corticosteroids and controller therapies for COPD. We also see that there are significant gaps in treatment. In this example here, someone took medication for 90 days and then had a gap of like 50 days. Then they took another 90 days of medication and then a 100-day gap. So there is concerns about overall adherence as well as persistence. And medication persistent possession rates, another way of looking at this, also shows that it's quite low for COPD. So the size of these little kind of squid-like figures is representing the number of prescriptions written in the US, and then the mean medication possession rate is lowest for that group in COPD, who have only about 50% of their medications on hand. And one study showed that 40% of all patients who die from COPD had no COPD medications on them for the 12 months prior to their death. So that means that in order to improve some of the outcomes in this disease state, we really need to move away from older models of engaging patients to really think about a shared decision-making approach. So moving away from a paternalistic model in which the clinician decides what's best for the patient based on evidence-based data, moving away from providing information where a clinician simply gives the patient facts using a patient education strategy. Again, moving away from even an interpretive model where the clinician gives the patient the facts and help them find their preferences, to one in which there's a real deliberation around treatment choices, where not only does the clinician give the individual facts based on the evidence, helps them find their preferences, but also shares their preferences, which we would consider shared decision-making. And even data that's been as recent as 2013 have showed that there's a continued clinician-directed patient communication style in 3/4 of interventions, as opposed to this kind of patient-centered shared decision-making model that we'd like to move to. So the shared decision-making really should be the nexus of data that comes from the best empirical evidence, the practitioner's expertise in the disease state and in their clinical skill set, as well as equal weight being given to the client or patient's needs, values, and preferences to arrive at a decision. And this work comes from Elwin Group, who really talk about a three-step approach to shared decision-making, in which there is team talk, where the clinician explains their intention to collaborate and discuss options for disease management, so that the individual moves from what might be their initial preferences to a more informed preference that is constructed through this shared decision-making process that culminates with decision talk, in which the clinician elicits those preferences and makes a plan to integrate those preferences into the treatment plan. Although shared decision-making is part of patient-centered COPD care, there has been no study to date where COPD has been studied alone in shared decision-making interventions. We know that shared decision-making can be further bolstered by using motivational interviewing together with shared decision-making, which is an attempt to engage the individual so that you explore and resolve their ambivalence to self-management, tipping their decisions about self-management towards those things that are more evidence-based or more likely to improve outcomes. And that delivered in a brief intervention, where there is a single intervention of as little as 5 minutes delivered in non-traditional settings, using non-traditional interventionists, can be quite powerful. So our pilot is aiming to use this shared decision-making intervention with motivational interviewing in a brief intervention, and we call the project Breathe ALD, which stands for Brief Intervention to Enhance Adherence to Treatment and Health Advice in Advanced Lung Disease. And we have three specific aims: to develop a script that the COPD and ILD providers will use to help them engage with self-management decisions using interviews, to do a feasibility and acceptability evaluation of the intervention, and then, if possible, to explore intervention effects in this shared decision-making, motivational interviewing, brief intervention by following patients monthly for 3 months post a single intervention. So the first aim would be to actually develop the script by doing semi-structured interviews with 10 patients and 10 caregivers, and then conducting a process and implementation assessment to address feasibility, and conducting post-trial interviews with all involved to assess acceptability. The third aim then is to do a small pilot trial of Breathe ALD, in which we would train a healthcare provider to deliver the shared decision-making, motivational interviewing intervention in a single brief visit, compared to a healthcare provider who delivers a dose-matched attention control intervention that is focused on healthy lifestyles. We would use the 4 steps of motivational interviewing to engage the patient, drawing connections to how they're currently doing to how they hope to do, enhancing their motivation, and then planning for how they're going to move forward from that visit, using that deliberation 3-step talk that I had described earlier. We then plan to integrate this intervention into a single inpatient or outpatient visit with as many as 20 patients randomized to the active and 20 patients randomized to the dose-matched attention control, in which we will audio record those sessions, score them for fidelity of the clinician to deliver the intervention, giving them feedback, with the goal of the intervention lasting no more than 9 minutes, whether it's tailored to the beliefs undermining their current self-management or the active healthy lifestyle discussion. And then finally, we would measure the shared decision-making perceptions immediately post-intervention, and then follow individuals for up to 3 months, looking at outcomes of COBT assessment, common data elements, promise measures, quality of life, as well as things such as breathlessness and adherence. So with that, I'll stop sharing, and I don't know if we're taking questions now. We're going to hand it over to Bevin.
I'm not in charge, but certainly I think if you want to take some questions, that would make sense.
So do we have any question for Dr. George?
So I have one thing that I'd like to say. Can you hear me? Can you hear me?
Yes.
Oh, sorry. I'm with this crazy thing. You know, having done a lot of clinical work over the years, I think pulmonary disease is one of the most challenging areas for palliative care to break into. And I think that you raise a good point, and we need to really think about this as we plan interventions for the future. Pulmonologists like to manage their patients long term, and they also like to work with providers who have a clear understanding of the trajectory of illness. And so when we think about educating for the future, it's really important that palliative care nurses and nurse practitioners understand that patient from the outpatient setting to the inpatient setting to the ICU. So that complete trajectory of illness, to have a clear understanding of prognostication and how we're talking to patients and families is really important for the pulmonologist to accept palliative care interventions. And if that's done by a specialist team or a primary RN NP team working with the pulmonologist, I don't think it makes much of a difference, but I think the trajectory is really important to understand that.
Yeah, I completely agree. And that's why I'm glad I'm going to be working with you on this.
Had my face chewed off many a time, but I could survive because I had been an ICU nurse and I understood the physiology clearly.
Yeah, I'm going to follow on Dr. McHugh's comment. What do you think the COPD patient who are coming to the home health care, do they have different needs regarding the palliative care, like sleep management?
Mm-hmm. Yeah, I mean, my experience with a lot of the COPD patients, they have a personality that's very different from a lot of patients. And they tend to be, they like to move around, they like to do things, they sometimes can be agitated. It's just who they are as a baseline. When they get home care in, there tend to be a group of people who don't accept home care initially. They want to do everything on their own. When they get home care, there is some, and palliative care home care, there is some data out there that their life expectancy is actually longer than we initially anticipate. And if you think about that, they're getting the help that they needed all along, but they never asked for it. Most COPD patients don't have a skilled need that allows them to get on home care. They do everything themselves, but they have lung functions that are poor prognosis. So once they get on hospice and palliative care programs, they're the ones who tend to extend what we think will be their life expectancy. But they have chronic infections.
And I just want to, echo that that low rate of uptake. So I had mentioned that 20% will accept telemedicine, which was a hope that they would improve acceptance of kind of home care services. Telemedicine didn't do it. Then also trying to get people referred into and accept pulmonary rehab programs, which have been shown to improve symptoms and increase survival. And the acceptance rate of patients to referral to pulmonary rehab is around 5%. So a group of individuals who are kind of more interesting and challenging in that they've had a chronic disease, they've been accommodating to that disease over a period of time, don't see the benefit of doing anything different that they currently been doing, although the data clearly shows that their symptoms would be reduced and their survival would be increased if they were to agree to these referrals and services.
Thank you. Do we have other question for Dr. George? Okay, if not, we're going to move to Dr. Cohen's presentation.
Thank you. I'm going to go ahead and share. And if you don't mind just telling me if you see this correctly. Yeah? Okay, great. Thank you. And I'll warn you.
We are seeing your two slides.
That's what I thought. I don't mind that you see it. I wanted to make sure it was big enough for you. Is that better?
Yes, that's it.
Is? Oh, excellent. Okay, good. Thank you. And while Maureen had beautiful slides, I have kept these very simple and made the font huge because I find that I'm always on Zoom looking at my tiny laptop screen and I can't see anything. So I apologize that they're ugly, but hopefully you can see the fonts. So our pilot is titled Developing a Comprehensive Program of Primary Palliative Care for Vulnerable Adults with Multiple Chronic Conditions. And I know that everyone who attends these calls is pretty well familiar with palliative care in this population. So I'll just give a pretty brief background to motivate why it is that we're doing this study. We know that patients with multiple chronic conditions are typically managed very fragmentally across many different specialties. And this tends to result in them having poor control of their symptoms, less than adequate disease management, lots of unplanned care in the emergency room and acute care admissions, which of course in turn leads to high costs all around. So there's some emerging evidence that primary palliative care may actually improve some of these outcomes, but as we know, this has not been the model. So when I talk about primary palliative care, what I mean by that is the patient's primary care provider actually incorporating some of the elements of palliative care into the primary care visits that they're already doing with their patients. So we know that palliative care traditionally has existed as a specialty outside of primary care, but there's a new focus in the literature now on trying to upstream palliative care for patients who have multiple chronic conditions. And one way of doing this is by improving the integration into the primary care that patients are already receiving. So the purpose of our study is to draw upon models of care that already exist to develop a comprehensive palliative care program that a primary care practice can readily adopt into their current practice. So the four models that we draw from are primary palliative care, which is sort of new and emerging. There's also home-based primary care. So for patients who are not so ambulatory and have a difficult time getting in to see their providers regularly, home care visits are a great option for them. There's home-based palliative care, which has existed for some time, but is usually reserved for the sickest of the sick patients and people who are very, very close to the end of life. And lastly, we have social determinants of health-driven care. And by this, I mean taking into account the patient's environment, the resources that they have, the caregivers that they have, so that when care is being planned for that patient, the provider can better draw and understand what that patient's support system and environment looks like to try to match the care goals with the resources available and try to get patients the resources that they need. So the setting for this study is the Columbia Doctors Nurse Practitioner Group. It's the faculty practice for Columbia School of Nursing. It's a primary care practice serving the Washington Heights community. It's a national committee for quality assurance, patient-centered medical home. Serves about 2,000 patients, and about 15% of those are adults with multiple chronic conditions. And when the practice is fully staffed, there are 5 primary care NPs 2 psychiatric NPs, and 1 registered nurse. And I definitely want to mention the team for this project up front, because it's a pretty incredible opportunity to combine people with lots of different areas of expertise from different segments that touch palliative care for these patients. So first, in the primary care practice, it's run by Stephen Ferrara. Marie Garçon is the NP who leads the home visit program. Diana Hernandez is the practice manager, and Rakaya Jones is a nurse practitioner, but also someone who is very knowledgeable and skilled with the Epic EMR, building notes, and also knowledgeable about the billing and how that aspect ties into how patients with multiple chronic conditions are managed. Similarly, working with the Accountable Care Organization of New York Presbyterian, led by Dr. Paul Casal, with lots of input from Karen Donikoff, Amy Matthew, and Judith Thorpe, who are nurses and nurse practitioners who have a lot of experience with telephonic chronic care management for patients with multiple chronic conditions. So their perspective on how to manage patients over the phone and do that care coordination piece has been very, very helpful. On the research side, in addition to me, Christine DeForge is a doctoral candidate at the School of Nursing, and John McHugh is a researcher from the Mailman School of Public Health in health policy and management. And last but certainly not least is Marlene McHugh, who brings the expertise in palliative care education and palliative care nurse practitioner practice. So brings that whole angle into this. So it's a really, really nice team with many different expertise tied in. So our first aim is to simply explore the needs, the palliative care needs of adults who have multiple chronic conditions who live in the catchment area of this primary care practice. And we began by interviewing patients and their caregivers to ask them about barriers and facilitators to managing their symptoms, managing their disease, having discussions about goals of care with their providers, both in the primary care setting and also in specialty care settings or acute care, and also asking them about palliative care. Do they know what that is? Once they understand what it is, have any of the elements of palliative care been incorporated into care for them, and how did they feel about that? So on the flip side, we're also interviewing clinicians and administrators, thinking about their knowledge, attitudes, training, and experiences with delivering primary and specialty palliative care, depending on the setting in which they work, asking them about barriers and facilitators to helping patients manage their diseases and symptoms in the context of multiple chronic conditions, and also just soliciting ideas about how would you improve care coordination? What are the sticky points here? How can we better deliver this care? So I'll move on. This is the shameless plug section of the presentation, in which I invite you, if you are a provider of any kind, or an administrator of any kind who deals with patients with multiple chronic conditions, and you have an interest in sharing your perspective with us. We are currently still recruiting for the study. It's about a 30-minute interview. The interviews are conducted by my colleague, John McHugh. His email address is at the bottom. So certainly if you or anyone you know would be interested in sharing your experiences with us, we'd love to have you as a subject in our research study. So moving on, aim 2 of our study is actually developing that comprehensive primary palliative care program for our patients with multiple chronic conditions. And we're developing this program in 3 distinct buckets. So the first bucket is provider education. The second bucket is standardizing the assessments and documentation for patients with multiple chronic conditions. And the third is sort of changing up the workflow so that there's a team-based approach to care management for these patients. So first, on the provider education side, all of the providers in the practice are going to be completing the core LNEC certifications. I believe it's 8 one-hour modules that just give a broad base of palliative care for people who are not so familiar with sort of the fundamentals of palliative care delivery. Then we also developed a curated list of modules from Metropolitan Jewish Health System and the Center to Advance Palliative Care, so MJHS and CAPC. Both of these organizations offer either free or low-cost modules and webinars and different types of trainings that are very specific to certain topics. So for example, if a provider feels I really need more confidence with discussing goals of care advanced directives, they can find a module that meets that training need. Or if they really have a particular issue with a particular type of symptom or pain for a particular type of patient, there could be a module that very much speaks to that training need. So we're going to give them this list and ask them to sort of use these trainings as needed to supplement. And lastly, we're doing lunch and learn overviews so that everybody is sort of on board and understanding what the whole program is about, an opportunity to get education on the specific assessments that we're going to be asking them to do on all of their patients, and also just have a little bit of Q&A, and Marlene McHugh is going to be leading these sessions. So the second bucket of the intervention is standardizing the assessments for patients who have multiple chronic conditions who are seen in this practice. And to do this, we spent a lot of time with all the key stakeholders trying to build an EPIC note that would be extremely comprehensive in terms of the information that's being collected about the patient at every visit. So some enhanced background information that really ties in a lot of the elements of palliative care. So asking about their caregivers and their caregiver support, all of the people who should be contacted about their care and in an emergency, language requirements, their religion and spirituality, and whether or not that's a comfort to them and something that they want involved in their care decision making. And lastly, many elements of social determinants of health. Then we're also adding 6 assessments for symptoms, pain, and functional status. So that's the Edmonton Symptom Assessment Scale, the Karnofsky Performance Status, the Palliative Performance Scale, the PROMIS 3-question fatigue, the PROMIS pain, and the PROMIS 36 health survey. In addition to that, we're asking them to take note of a couple of key prognostic indicators. So for example, albumin, weight, and any recent imaging. And lastly, we're asking them for patients with whom they've already established a relationship, to open a conversation about goals of care, and then as that progresses, documentation of advanced directives in the electronic medical record. So the third bucket is a team-based approach to care management. And this is sort of the new piece of workflow that's going to be integrated into the practice. So there's going to be a registered nurse calling the patient before they come in to see their provider, and going through all of those assessments and background information that I discussed on the previous slide. The RN is going to actually be collecting that with them and establishing a relationship with that patient over the phone before they even go in to see their NP provider. And then this gives the NP an opportunity to review the information before they see the patient and incorporate that into the patient's care plan, and highlight anything that needs to be addressed during the visit. So the hope here is that it saves time and that the data doesn't need to be collected during the visit, and also gives the NP a little bit of a heads up about what's going on with the patient before the visit. And then after the patient sees the NP, the RN is actually going to follow up weekly to update any of that information, and in particular, those pain, symptom, and functional assessment scales. And if anything comes up that needs to be flagged, the RN can then ping the NP and schedule an urgent or time-sensitive visit as needed, so that we could potentially avoid some of that unplanned care or a trip to the emergency room. So this is the new workflow that's going to be rolled out. So aim 3 of the pilot is to assess the feasibility, acceptability, and the perceived utility of the intervention. So It's not a study of efficacy, so we are going to be collecting some outcomes data, but the study is not designed nor powered to really do any comparisons in terms of a pre-post or a prospective study. But we do want to make sure that we could at least describe some of the data, such as are these assessments being filled out? Is the advanced care planning being done? How frequently are patients coming in? How frequently are they being followed up by telephone? And then how frequently they're having unplanned care or acute care visits, and also the length of stay of those visits. So that's one piece of our feasibility assessment. We're also going to be doing interviews with providers to determine the acceptability and perceived utility of the intervention, specifically asking about the training that they received, whether they thought that the assessments that they're doing had added value, the time burden of those assessments, and any other feedback that they want to share about that. And then we're going to be interviewing, of course, patients and caregivers to assess their experiences with completing the assessment, because there's certainly a time burden on the patient as well. So we want to hear their feedback. We want to hear how comfortable they felt with discussing goals of care and advanced directives and whether they thought that was valuable, and also their satisfaction with receiving telephone calls, how frequently they received them, and whether or not that had an impact on their well-being. So I just want to end by, bringing up a few real-world challenges to doing this type of work that we've come across thus far. The first is, in a real practice, you're going to have some provider turnover, and we're already experiencing some of that. So when you're dealing with something that's a little bit new and you want to make sure everybody has the same baseline education and is very familiar with, the note that they're going to be using, it's just sort of an added challenge to make sure that as new people come on board and old people, but your former staff leave, that everybody is sort of up to speed with the training. The second issue that we've come across is just time and timing. So of course there is a time burden associated with doing all of these assessments, both on the patient side and on the provider side. So thinking about how to really condense it and make it quite efficient for all parties, and also thinking about the timing of when these assessments are done, because the idea is that, before somebody comes in to see the patient, they'll have already had this telephone call, but of course you're dealing with the real world, and what if the patient's coming in on a Monday and the day before is a Sunday? How do we schedule that in a way that the information that's being collected is still very current and relevant, but it is done in a timely fashion before the visit. And lastly, and perhaps, unfortunately, most importantly here, is the billing piece. The notes and visits and RN visits versus NP visits need to be connected in such a way that the time could be billed for. And this is a little bit challenging to navigate, and it requires that notes are constructed in a certain way and linked to different visits in a specific way. So it's an unfortunate reality that we need to be very attentive to that in the design of an intervention like this. So that's all I have, but I welcome questions, and I'll also note that several members of our team are also on the call. So if there are any questions you'd like to direct to them, please feel free to do that as well.
That's very good. So do we have any question for Dr. Cohen?
I just want to say one thing. It's not a question, but I think that this is really innovative. We have built very successful palliative care projects, initiatives within inpatient settings, and there's a tremendous need for outpatient work. I truly believe that nurse practitioners and nurses are going to lead this initiative across the country. I think the challenge, and that we all have to think about, is the complex illness in the community is increasing with decreasing hospitalizations. And we need to really be thinking about how we're educating a next generation to be able to provide this level of care. It's a conversation that's happening in medicine, and we also need to be having this in academic nursing. These patients are 24 hours, 7 days a week. Management, I see Abe Brody on here. He's done a lot of this work in the community. And we need to be developing workforces who can manage this complexity and provide really great care to these people. A lot of people are doing it. We haven't recognized it, but this is the next generation of palliative care, and nurses really need to get this work out and show what they're capable of doing in terms of serious illness management. So I congratulate you. Everybody's looking to figure this out.
Okay, thank you, Dr. McHugh. So Bevin, I have a question. So you are talking about the timing, and actually I had a question during your presentation is if the patient's symptom changed when they arrive at a clinic, do you have any way to capture, maybe ask a question, has your symptom changed since we last talked, and how you can incorporate this into the planning your care?
Yeah, thank you, Jingjing. That's a really good question. It's definitely something we talked a bit about, and especially with Marlene's kind of expertise in how quickly, certain types of symptoms are probably going to be pretty stable, and certain types of symptoms are probably, going to fluctuate quite a bit and can change very quickly. So there are certain scales that, part of the provider education is going to be, this is a scale that needs to be completed day of. This is a scale that probably, if it's a couple days old, you wouldn't need to redo. So, certainly there's a provider education piece there to look out for things that we know probably will change. And then the goal of this is sort of for the provider to, do a little quick rundown, before the patient comes in and flag, okay, this was an issue, this was an issue, this was an issue, and have that discussion with patients, and also open the floor to say, okay, your pain was well controlled when you spoke with Judith on the phone. Is it still well controlled, right? So I agree that we need to, build in prompts and remind folks that it is sort of a conversation to assess and get as updated information as possible at the time of the visit. But certainly that's the point of having the weekly calls afterwards, is to pick up on trends and differences on a week-to-week basis. So weekly, the RN on the telephone is actually going to be redoing all of those assessment scales. But in terms of the day-to-day changes, if you spoke to the RN on the phone and then you came into the clinic, the NP is going to be sort of initiating that conversation and just making sure that everything has sort of remained the same and picking up on anything that has changed. I hope that answers your question. Let me know if not.
Yeah. Yeah, that is very good. So just like I'm thinking about the intervention you have if you want to have a wide implementation to all the clinical practice, the pre-visit call is wonderful, but not a lot of practice can do this. Have you think about, maybe this is after the pilot finish, is think about generalize a more like simple screening, which can be done before the patients see the NP or the physician during the nurse assessment, a very simple assessment done, and then we'll automatically enter into the computer system. Maybe we can develop an algorithm to trigger what these patients need to have, like a palliative care talk with the provider. So that can be something follow your pilot study.
Yeah, I completely agree, and I'm glad that you brought that up. I think part of this is going to be to determine which ones of these assessments actually have value, and that's what we hope to get out of our interviews after the intervention with providers and also with their patients in terms of the burden of doing the symptom the various scale assessments. So understanding which have the most value in this context, so that we can make this much shorter, because you're absolutely right, in a rollout out beyond a research setting, it's really not feasible to have this many questions. And the other piece, Jingjing, I know you know this well, but we are a little bit constrained by the funding mechanism here, in that we have to include very specific measures that are dictated by NINR. So that's sort of why we have some things that we think are very valuable to patients that are recommended by Marlene's many years of experience, and then we have some things that are sort of required per NINR for this mechanism. So we'll sort out at the end sort of which are the ones that should be kept in the practice setting. Yeah, it's a very good point.
Okay, very good. Thank you. So do we have other questions for Dr. Cohen? Okay, if not, I have a few announcements for our SIPC. Let me see, where is the... Yeah, so we have two more seminars coming up in this month and in May. So on April 15th, we have a SIPC presentation by Dr. Jean Cutler. And her topic is developing a career in palliative care research. And then on the May 6th, we have a SIPC poster presentation. The topic is building the next generation of palliative care researchers and clinicians. And we will have a keynote speaker by Dr. Rosa and Dr. Knoll from University of Miami, and that will be moderated by Dr. Farrell. So we look forward to seeing you in our next sessions. And if you have any suggestion for the topic you want to hear from our center, please send email to Ashley. And thank you all for coming to our session. Okay, so do we have other questions for the pilot or for any of us? If not, you all have a good day, and we will see you in our next seminar session.